This webinar couldn't have come at a better time. We all live in such surreal times, just like a disaster movie. The media is full of sad news of social distancing, lockdowns, number of COVID cases. And this applies to the whole world for that matter. So nothing really more welcome than to have this webinar and to listen to exciting talks from very carefully chosen panel of expert speakers. Just to say that OCT and OCTA imaging is indeed a revolution in ocular imaging. It has transformed very much the way we define disease and understand pathology. The technology is very much still in evolution, and one aspect of that, the evolution is extending its boundaries beyond the posterior pole. Also, for many years, we've been hearing a lot about artificial intelligence in radiology and its applications. So not surprising, really, to see this technology has found its way into ocular imaging. And certainly, I can say Canon has led the way in this field. So we'll hear more about that in a minute. So I'll say no more, as I'm sure you're all excited to listen to our panel of experts who are going to share with you their experience with this technology. If I can introduce our first speaker, Professor Paolo Stanga. He's Professor of Ophthalmology and Retinal Regeneration at the University of Manchester. He's Chairman of the MREH Research Steering Committee, where he leads in the development and introduction into clinical care of medical devices, both diagnostic, imaging, and therapeutic, as well as new surgical techniques and therapies. Also being consultant ophthalmologist and a VR surgeon at a very busy hospital, gives him tremendous insight into the new Canon Xifilio S1, which is a swept source OCT scanner. And he will now share with us his experience. So over to you, Paolo.
Thank you very much, Sol, for this introduction, and thank you very much to Canon for this invitation. It's a privilege to share this podium with not only people that are interested in this same technology, but friends. So let me share with you the work that I do at the London Vision Clinic in London. So let me share with you our experience with single capture wide field swab source OCT technology for imaging the mid and peripheral retroretinal interface and neuroretina. I would like to acknowledge my co-authors, Salvador, Pooja, Ori, and Dan. So these are my commercial associations. And let's start by saying that mid and peripheral retroretinal interface abnormalities span a wide range of retinal conditions. There are incidental findings like white without pressure, lattice, retinoschisis, and findings that require active management like vitreoretinal traction, retinal breaks, or retinal detachment. Current approaches to detect peripheral retinal pathologies are based on dilated fundus examination. However, most examinations, as we know, only include slit lamp biomicroscopy. However, for a complete aura-to-aura retinal examination, dilated slit lamp examination is not enough, no matter what lens we use. Even ultra-wide field imaging is not enough to reach the aura. The only way to reach the aura is by doing indirect ophthalmoscopy with 360 degrees scleral indentation. So here you can see how very gentle pressure applied to the skin of the eyelid is enough to move the aura or displace the aura into view. Back in 2014, we showed that swab source OCT technology, and we published this in the American Journal of Ophthalmology, was the best technology to visualize the cortical vitreous and the vitreoretinal interface. And the reason for this is because infrared illumination, it reduces light scattering by the collagen fibers in the vitreous, and the high-speed scanning of 100,000 A scans per second reduces the impact from not only eye movement, but from the movement of the collagen fibers. We have to remember that the vitreous consists of a system of cisterns that had been identified by Wurst amongst others. Imaging the peripheral retroretinal interface in your retina is therefore or can be considered a landmark achievement, because early recognition of lesions that need treatment or increased risk of retinal detachment is essential. This can enhance clinical decision-making in suspicious images where a retinal specialist may not be readily available, telemedicine. It can change clinical management. It can reduce the number of patients suffering from retinal detachment and needing surgery. And as I said before, essential for telemedicine-based triage of retinal pathologies affecting the periphery. We talk about multimodal imaging nowadays. I would like to say ultra and wide field multimodal imaging. Here we can see in a single image the presence of red blood cells in the cortical vitreous, the presence of vitreoskisis, schitic changes in the neuroretina secondary to traction, a tabletop vitreous detachment, an epiretinal membrane, and a minimum of cystoid macular edema, all in a single 23 millimeter long scan. Ultra-wide field imaging and wide field imaging are increasingly being used. The advantages of ultra-wide field and wide field imaging may be particularly apparent in patients with poor pupillary dilation, mediopacity, or excessive eye movement. Wide field OCT is capable of capturing retinal areas beyond the posterior pole, can be a valuable method for evaluating peripheral vitreoretinal interface abnormalities. So this is the technology that I use. I must say that all the patients that I see, of course, I do biomicroscopy. I also do indirect ophthalmoscopy. I do 360 degrees scleral indentation and multi-wavelength ultra-wide field imaging. But this is my preferred OCT technology at the moment. I use the S1 scanner. I use both the S1 and the A1, but for imaging the peripheral retina, the S1. 1,060 nanometer illumination in the infrared bandwidth, 100,000 A scans per second, axial resolution of 8 microns, horizontal resolution of 30, 80-degree viewing angle, and imaging depth of 5.3 millimeter. And this is very important because it allows deeper visualization into the vitreous. So how much is 80 degrees? This is 30 degrees, this is approximately 6 millimeters, 45 degrees, 12 millimeter, and this is the kind of imaging scan or length that we started with SwepSource technology, 50 degrees, and this is 80 degrees or 23 millimeter long scans. As I said, it is also important that the depth of the imaging window has now increased to 5.3 millimeters with this technology. As you can see, we go deeper into the vitreous. So here you can see the bursa primacularis, the space of Martegiani, cisterns in the vitreous cavity, and some vitreous floaters. We published as a group the classification and guidelines for wide field imaging. And what is wide field? We all talk about wide field and ultra wide field. Wide field should be limited to single images depicting retinal anatomy beyond the posterior pole, but posterior to the vortex vein ampulla in all 4 quadrants. So if we go past the vortex veins, then we are going into ultra wide field. So let me share some exciting examples with you. So this is a patient with peripheral retinal lattice, retinoschisis, as well in high myopia. So I have played with a wavelength here to enhance the vitreoretinal interface. But this is what I found exciting about this new technology. Not only we can see the vitreous or the posterior cortical vitreous attached to the area of lattice, but an impending tear. And this is in a patient that is symptomatic. So the question is whether to treat or not, but we found a reason for the symptoms in this patient. There is traction that is causing an impending tear. These are other examples of peripheral lattice lesion. And as you can see, the schitic changes in the peripheral retina secondary to traction. And here is the ultra-wide field imaging showing the lesion and how we can reach that area with the S1 scanner. A more magnified image from the same case, you can see vitroschisis, you can see the separation of the internal emitting membrane and schitic changes within the neuroretina. This I found very interesting because, again, whenever we see a patient with flashes of light and floaters, patients are mostly seen with slit lamp microscopy and told, well, you have a vitreous detachment. Okay, fine, that's all good, but we need to find the reason for the photopsia because we need to rule out tears. So here is the operculum of a tear still attached to the posterior cortical vitreous, and this I find fascinating. This is the edge of the attachment of the posterior cortical vitreous. So we can see up to where the vitreous is attached. And it is important for the patient, for prognosis, because the patient wants to know, am I still at risk of further detachments? Is the vitreous going to detach any further? Look at this example here. Very clearly we see the flap of the tear and the vitreous still attached to the flap of the tear, maintaining the symptoms. A patient with a tear of chronic duration, schitic changes within the neuroretina and subretinal fluid. This is a subclinical peripheral retinal detachment of long-standing duration. You can see the schitic changes and clearly the tear. This is an operculated hole which appears to have subretinal fluid around it, a CAFO fluid. OCT shows that there is no fluid. What appears to be fluid, in fact, is not. The retina is fully attached around the edge. There's no traction there. And here you can see a 3D rendering of this operculum. And this, what appears to be the hole, is not the hole. The hole is this one, and this is shadow cast by the free-floating operculum. But this is a beautiful example to explain to the patient what pathology the patient is suffering from, and assess whether there is residual traction on the edges of the hole or tear or not. Another example of rhegmatogenous lesion. Here you can see the free-floating operculum. The free-floating operculum is still attached to the posterior cortical vitreous, absence of fluid around the tear. This was a very challenging case because I could only see this on indirect ophthalmoscopy. You can barely see a faint area here that when looking again at the ultra-wide-field images after having examined the patient with indirect ophthalmoscopy and 360 degrees clear limitation, I noticed that this could be elevated. And indeed, not only it was elevated, but you can see a tear and you can see the posterior cortical vitreous attached. So this lesion being superior with a persistent attachment, this patient is at high risk of a retinal detachment. And you can see here the 3D rendering, the elevated vitreous still attached. This, I think, technology is essential in cases like this. Following treatment, of course, this area is more easily visible because it is highly demarcated. And you can see the 3D rendering, the attachment of the vitreous over this area of elevated retina because of subretinal fluid has gone through the tear, which is open and being pulled open and maintained open. So treatment is essential, and OCT not only confirmed the diagnosis because it was impossible to see the tear. I thought there was a traction perhaps only, but OCT confirmed the presence of a tear and the absolute need of laser treatment. This is a patient that I've been following up for a couple of years now. The patient remains symptomatic and OCT is the only way to see that there is persistent traction on this tear and it's causing the photopsia. Because every time I see here, there are no new tears, but there is traction and there is still an attachment, and this explains the reason for the persistent symptoms. A lesion where there is subretinal fluid inferiorly, no loss of vision, but photopsia, and here you can see the reason for the photopsia. An attachment of the posterior cortical vitreous, an open tear. This patient needed treatment, and I surrounded all this area with retinopexy. So essential, the OCT to confirm the diagnosis because the tear was very small, barely visible. Pigmented vitreous tuft. These are challenging lesions, sometimes diagnosed because they sometimes may look like retinal tears or pigmented holes. Here in this case, the OCT showed that the retina is continuous. There's no solution of continuity, no loss of tissue, no traction. So benign lesion not requiring treatment. However, look at this one. This certainly looks like a tear. And sometimes we look at these lesions and we say it's a pigmented tear. And some people say, well, there's no need for treatment because it's pigmented. There's a tear, there's been a reaction that secured the tear like Pexy. Well, this is what OCT showed. It is not a tear. It is a pigmented vitreous tuft. There's no solution of continuity. You can see the attachment of the posterior cortical vitreous. And I think this is a beautiful example of up to where the PVD has reached. So again, very helpful peripheral OCT in decision making. This is what I believe is a challenging case because when I looked at this patient, this certainly looks like subretinal fluid secondary to perhaps a tear or traction, but there is certainly a halo, which you can see here. However, OCT showed that the tear only affects the inner retina. It is not a full thickness tear. And here you can see some schitic changes secondary to traction that was must have been long-standing, in my opinion. And at some point, the traction was released, it leading to an inner retinal tear. So not a full thickness tear and not subretinal fluid. But I would have not been able to diagnose this unless I had access to peripheral OCT technology. And you can see here the 3D rendering of the posterior cortical vitreous. Snail track, retinal degeneration, benign lesion, no solution of continuity. It is not lattice. White without pressure, we see a lot of these patients. My colleague Dan Reinstein is one of the leading experts in ICL placement, so I have access to a lot of high myopes. So we see a lot of white without pressure, and I find it extremely interesting to see this increased numbers of collagen fibers in front of the retina, which in my opinion leads to the view that we get with ultra-wide field imaging. Floaters, vitreous floaters, and with infrared illumination, we see them very easily, but this is a patient where we can clearly see why this patient is uncomfortable and so symptomatic with its vitreous floaters is not only the clusters of collagen fibers, but look at the detached posterior cortical vitreous, the corrugation in the posterior cortical vitreous, making it extremely symptomatic. It is the posterior vitreous cortex that's corrugated and detached that's more responsible for the symptoms of vision-degrading myodysopsia than the actual floaters. We talk about posterior vitreous detachment, and the question is there really a posterior vitreous detachment? It can be very difficult to diagnose a posterior vitreous detachment unless you see a vice ring. Here we can see that the posterior cortical vitreous is only detached over the macular area, while in this example, there is a posterior pole vitreous detachment. Very clearly, you can see the edge of the posterior cortical vitreous that's come off, and this is very useful to explain to patients why they are so symptomatic. You can see the opacity in the posterior cortical vitreous. A patient of retinoschisis, sometimes this can be challenging for the non-retinal specialist, and they get concerned, is this retinoschisis? Is this a retinal detachment? Schweppes' peripheral OCT clearly confirms that there is an inner and an outer leaf and schitic changes. Therefore, this is confirmation that this is a retinoschisis, not retinal detachment, does not need any treatment. And here you can see the famous peau d'orange that we tend to describe. You can see the inner leaf elevated and the peau d'orange, which is the inner leaf. I think this is a beautiful example of peripheral retinoschisis. And to finalize, let me share with you this exciting case of a diabetic patient with proliferative disease, insufficient laser treatment, and OCT technology not only allowed for assessing the different vitreous attachments, areas of schisis, areas of tractional retinoschisis, but wide field OCT angiography is essential, I think, in diabetics to assess areas of non-perfusion and residual neovascularization. So let me conclude by saying that for a complete aura-to-aura retinal examination, dilated slit lamp microscopy is not enough. Peripheral retinal imaging has an increasingly important role in screening, diagnosing, monitoring, and treating retinal diseases. Findings in the periphery do not always associate with those observed in the posterior pole, as we commonly see in diabetics, where imaging the peripheral retina is a biomarker of prognosis. Imaging the peripheral retina can improve diagnosis and identify lesions that need treatment or increase the risk of retinal detachment. It provides an objective assessment of the status of posterior vitreous detachment and residual risk of retinal tears. It has the potential to reduce the number of patients suffering from retinal detachment with subsequent need of surgery. Wide field OCT imaging may facilitate a more accurate indication of treatment or rule out its need, for example, in lesions where there is only vitreoretinal attachment or traction or vitreous tufts. And let me finish by saying that I believed and maintained, and I was told the following. Back in 1998, when I started using OCT, I kept saying that OCT was essential for the examination, treatment, and monitoring of retinal patients. And I was being told, well, these are pretty pictures. They may help, but they do not replace fundus fluorescein angiography. I think it's unthinkable nowadays to have a retina clinic without OCT technology. In 2006, when I started using ultra-wide field imaging, and I thought it was essential and that it should replace 30 and 45-degree imaging, I was being told, well, my photographer is excellent. He can or she can reach the peripheral retina with a standard fundus camera. Again, you don't go into a room to assess, you don't assess the contents of a room by looking through the keyhole in the door. You go into the room, you open the door, and you assess the contents. And this is the equivalent of ultra-wide field imaging. In 2012, as I showed you before, I started using Schweppes OCT, and I said and maintained that it was the best technology to visualize the cortical vitreous and the vitreoretinal interface. And I was told by other companies, well, we can digitally enhance our images. And in 2019, I started saying wide field Schweppes OCT is essential to visualize the cortical vitreous, the vitreoretinal interface, and the peripheral retina. I maintain so, and I hope you have enjoyed this presentation. Thank you very much.
Thank you very much, Paolo. That was really amazing and stimulating talk. Lovely pictures and good illustrations. So thank you very much for that. For the audience who are listening, if you have any questions, can you please leave those questions to the very end? Click the button down below on your screen on the questions and answers. Write your questions, send them to me, and I will try and collate them to the panel at the end of the three talks. So we now go on to our next speaker, who is Professor Tariq Aslam. He is also a professor at the University of Manchester and a consultant ophthalmologist at Manchester Royal Eye Hospital, specializing in medical retinal disease. His research explores clinical ophthalmology, interfacing technologies, including image analysis, artificial intelligence, and device development. He's involved in multiple technologies with clinical applications, various patents, and medical software for social impact. He will share today his experience with the application of intelligent denoise on OCTA. So thank you very much, Tariq. Over to you.
Well, we're all hearing all the time about artificial intelligence and how much of an impact it's going to make on our lives. Indeed, we actually see it, whether we believe it or not, in our daily lives with the Echoes and the Google, a lot of the search engines we're doing. But actually, when we think about the numbers of papers that have been produced on artificial intelligence in retina, there have been relatively few instances, I think, in my daily practice at least, where artificial intelligence is currently being used. So I was really excited to see this technology when Canon first came to me, demonstrating an impact of artificial intelligence, which we can use on a daily basis currently right now. And these are some of my collaborators in Manchester and my disclosures. So what I'm going to try and do in this talk is present the intelligent denoise for OCTA images. I will talk about the principles of how it works, the principles of artificial intelligence, and then give you some examples of how this works in particular, and a study that we did in Manchester around the denoise of the images. I'm going to give you some example images that we've had in the recent months over in Manchester. And then finally, I'm going to talk a little bit about the research potential of these images. So firstly, just as an overall overview, the intelligent denoise system is a way that with the Canon imaging, you can, at the push of a button, improve the quality of the OCTA images. So you take the OCTA image as normal, and you can, at the push of a button, improve its quality so that you increase detail and improve the visibility of vasculature. Well, how did they do this? Well, this is a diagram which is much seen these days, and it represents a deep neural network. And I just want to talk about the basics of how a neural network works. It's a principle that is used a lot in current artificial intelligence applications. And basically, what you have is a series of inputs, and you have an output. And on your left, you see the input layer, lots of little nodes. And on your right, you see the outputs. And what you can do with a modern algorithm is provide a set of inputs and outputs and ask the computer to try and determine how you can adapt the inputs, multiplying, add things numerically to get to the outputs. And if you do this with enough sets of data, you finally train the system, so you can train the neural network, so that if you provide it with a fresh input layer, it will automatically create what the output should be. So that is the basis of machine learning with neural networks. Essentially, it's like a regression system where it can learn from previous examples and then apply it to a future one. So how does this relate to enhancing OCTA images? So what Canon did with this software was to have loads and loads of sets of standard OCTA images, and then also have, for that same patient, some averaged images, which were the highest possible quality. And it trained a neural network using sets of these images, different sections of individual images. So in the end, it was thousands and thousands of sections of images, with the output being the averaged perfect images. And over time, when you train enough systems, they eventually produce this trained, what we call convolutional neural network, which allows the system just to take the input and apply those algorithms that it's learned to automatically produce an output image, which is the equivalent or enhanced average. So these are the sorts of images we get. And, I still look at OCT, standard OCTA images, and I'm still at the stage of looking at them and thinking, wow, how are we getting this sort of image from without injecting any dyes at all? You can see that the image is even better, very demonstrably, just to the naked eye from the denoise image. And this is literally just at the push of a button on the software. And this is a bigger overview, a bit more of a detailed one. This is without the denoise, and this is with the denoise. So you can see there's a very clear change, and the overall image looks a lot clearer, and you can distinguish the vessels, especially the capillary vessels, a lot more. Now, one of the things with OCTA relative to OCT, OCT already has a lot of processing of the image, and OCTA enhances that even more. So there's masses of processing in terms of artifact removal and prevent and sorting out the different layers. And what we have to be careful of is that we don't introduce new artifacts or remove existing anatomical structures. So it was important to us that we took this system and actually checked it piece by piece, that we weren't producing new vasculature that wasn't already there, or that we weren't losing items of information that was in the original images. So this is a study we did in Manchester. We took 50 or so images, and for each one, we separated it into lots of different sections, including looking at the superficial plexus and deeper plexuses, looking at first and second order vessels and capillaries separately, and we compared the baseline image to the same image with the intelligent denoise applied. And we wanted to ask the expert reviewer, were there any anatomical features that he felt were lost, or were there any new features that could be misleading that were created? And then finally, we asked about some other general questions, such as what was the overall preferred image, and if there are any other comments from the study. And we looked at a variety of different pathologies that this slide shows. And so this study really confirmed what we thought in advance. Essentially, the technology is excellent. There weren't any areas where we thought that there were any anatomical features that were somehow created that weren't actually in existence, nor were there any true features that were lost. And especially for the superficial capillary plexus, 98% of the time, the enhanced image was far better than the original denoised image. The difference was less so for the deeper layers. Then the deeper capillary plexus, the enhanced image was preferred only in 16%, and the other images were about the same. So the impact of this is that we get enhanced images almost all of the time for the superficial plexus and some of the time for the deep plexus, which don't introduce any new features, but actually make clearer the features that were already there. And here's some examples now if I go into the second section of my talk. Now, I use OCTA a lot now, especially for CSR. So practically every patient who has CSR, I ask for an OCTA in, just because you quite often can find some hidden neovascular membranes. You can't always see them even on angiograms or just on the OCT, but you can find them picked up relatively with greater specificity and sensitivity with an OCTA. And the Canon system allows me to do that with quite a broad area here. You see in a 10 by 10 image. This is a patient who attended for the first time. It was during the COVID lockdown, and we weren't able to get lots of imaging, but we were able to get an OCTA, and he attended with unexplained loss of vision. So there were no hemorrhages or anything in his fundus at this stage. The loss of vision happened quite a while ago. He wasn't sure. And you can see very clearly the explanation of it with lots of areas of ischemia and a really beautiful OCTA image. Again, just to remind you, in case like me, you're still incredulous of this is an OCTA image. It doesn't involve any dye at all. It was just the patient basically sat at a machine for a few seconds to take this image, and then a button pressed to enhance it. And this is the same patient. We can get a bit wider with a mosaic image. Doesn't quite reach Paolo's 80 degrees, but this is about 60 degrees. So again, fantastic ability to get really, really clear images of vasculature, demonstrating all this dropout here. This is a patient from a colleague of mine, Laura, who deals with uveitis patients. And it shows really clearly areas of ischemia, but also, most importantly, this area that you can see there of neovascularization elsewhere. You can see from the pattern of it that it's likely to be neovascularization. But in case you weren't sure in other areas, if there was a smaller area, for example, would look different, you can see from the B scan on the left here that where you see these yellow lights, these indicate flow. So there's very, very clearly this neovascular flow that's occurring anterior to the retina. So a beautiful image there demonstrating exactly what's happening in this patient's fundus. And this is it in closer. This is a final slide just as an example of somebody who actually had congenital cataract. And despite the congenital cataract, we were still able to get this really nice enhanced image. And she, again, had some occlusive retinal vasculitis. And you can see the areas of capillary loss there. And Laura, a colleague of mine, is using this sort of technology now to almost be able to monitor progress of patients she has with uveitis, including the vasculitis elements. So what is the research? I've demonstrated some of the research we did, which was just to look at the clinical validity of this denoise. I want to talk about some really exciting aspects of OCTA research now that we're doing in Manchester. This is a study that we have already done and had published in TVST. And what we did was we wanted to use the OCTA technology. You've seen how great it is at looking at vasculature. We wanted to use it to see if we could use it to differentiate patients who were diabetic but had no retinal findings at all. So on color imaging. So on the color imaging, there were no hemorrhages or cotton wool spots. They did not have any, or they were described as having no evident diabetic retinopathy, yet they were diabetic from normal patients. That was the one differentiation. And the second one was patients who did have diabetic retinopathy but didn't need treatment to patients with diabetic retinopathy requiring hospital care. And those two differentiations we thought would be really nice to be able to do if you could with a single machine in clinics outside hospitals, for example, A, to be a test for diabetes almost, and B, to be able to differentiate whether patients needed to be in hospital. Now, we only had 182 patients, so we weren't able to do the classical convolutional neural nets that I mentioned before. Those tend to need thousands, tens of thousands, if not more, patients to do training on. So what we did was I was able to write software that looked out and picked out specific features from an OCTA, so a form of pre-processing where we look at candidate features. So instead of having a massive amount of data in an image, from that, I've written software to take out just maybe 10 features the size of the foveolar vascular zone, the irregularity of the foveolar vascular zone, the what we call skeletonization percentage, and actually other small features that we thought from the literature might be useful. Of those 10 or so features we extracted, these on the left were found through the machine learning methods to be the most important. And those were not the foveolar vascular zone itself, but the ischemic areas adjacent to the fovea. So you see just in this image here, not the foveolar vascular zone, but just adjacent to it, some other little red areas which showed ischemia. Then the intensity of specifically the smallest, the capillary vessels intensity. And finally, what we call the skeletonization percentage, which is when you minimize all the vessels to just have one line, what percentage of the area is taken up by blood vessels. And we found some really interesting results. So we're able to, this is just from a small area, 3 by 3 actually, of the superficial capillary plexus, not looking at any of the layers at all. But we had an area under the curve of about 0.8, differentiating normal patients with diabetics, and even higher, about 90%, differentiating those who required hospital treatment to those who didn't. Interestingly, what we found was that in going from normal to diabetes, you lose intensity of the capillary vessels, and then going from diabetic to required hospital treatment, that's when you get the dropout, so you lose in skeletonization percentage. So these are really exciting findings, because these are things that we couldn't see by the naked eye, but we could find from the OCTA images. And what we really want to do now is extend that study using some of the Canon software. So you've seen how great the images we can get, even to a 10 by 10 level. So what we want to do is extend that, and there's a particular feature of the Canon software that allows binarization. And when I'm writing software, that is the area that I'm sometimes most nervous about. Although it seems as simple, you can apply a simple threshold, but it doesn't always get all the vessels as clearly as you should. So having that feature allows me to be a lot more confident about my algorithms. And the second thing is that we get such a clear image of the superficial plexus to such a wide area. I think this is going to be really useful. We're going to carry on the same work and differentiate diabetics, but we also, interestingly, want to look at this in COVID patients, because we know there are microvascular changes in COVID patients, and that we've known from some papers that are beginning to come out that there might be OCT changes, and shortly to be coming out on the OCTA changes. Now, existing groups so far sometimes haven't found those OCTA changes, but I think with our software, we might be able to find those areas where the naked eye looking at OCTA image can't differentiate the difference. So I'm really excited about that work that hopefully will be coming out in the next few months. So that was a whistle-stop tour on my experiences of OCTA. I'm really delighted to have an application of AI that we can use on a daily basis. In its role in image creation is really useful. There is roles moving forward, I think, in image analysis, and the research that can come from this will, I think, give us a wealth of data representing not only the ocular images and the ocular pathology, but also systemic health, potentially for diabetes, which we've already demonstrated, and maybe for, which is relevant now for COVID or long COVID type syndromes. Thank you very much for your listening, and I hope you enjoyed that.
Thank you very much, Darek. Can everybody hear me now? Yeah. Yeah, thank you very much, Darek, for showing your real intelligence on artificial intelligence. That was really most enlightening and very stimulating. And no doubt it will stimulate a lot of questions. So we'll come to the questions later on. So please, any audiences have any questions, those who joined us a bit late, keep the questions, send the questions now using the question and answer tab, and I'll present them to the panel at the end of all three talks. So our next speaker really is Professor Giovanni Staurenghi. He's Professor of Ophthalmology, Chair of the University Eye Clinic, Director of University Eye Clinic Department of Biomedical and Clinical Sciences at Luigi Sacco Hospital in Italy. Professor Staurenghi is a scientific advisor of the Digital and Geography Reading Center, a member of the editorial board of Investigative Ophthalmology and Visual Science. His research, publications, and lectures have an important bearing on retinal degeneration, with special focus on different types of imaging and treatment. He has prepared for us a talk on wide field imaging. So over to you, Professor Staurenghi.
Thank you very much, first of all, to all of you and Canon for inviting me for this really nice meeting. I probably you realize, the quality of my, colleagues that presented before, and I hope I will be able to do at the same, be at the same level. So wide field OCT and OCTA images, and you already heard a lot about that. I will try to, in some way, add something, but also summarize. The importance of, these are my disclosures. Oops, sorry. When you look at the landscape, you're probably focused on some area, for example, this mountain. But if you don't look widely, you probably will miss the most important area here in this landscape, the famous dry xenon. Now, as Professor Stanga already said, we organized, a meeting for understanding and classifying better the wide field imaging. And in particular, we have the definition of wide field, ultra wide field, but also looking at the OCTs, differentiating the equatorial, the far peripheral, or the mid peripheral. That it's something that in some ways a new approach, as Professor Stanga shows in his lecture. The other interesting thing is that we have to keep in mind how we measure the degrees. So we can actually do a measurement from external angle or the corresponding angle. And you see, for example, the Optos, the famous 200 degrees that correspond to 155. And if you take, for example, I don't want to be, I disclose my, I disclose that I'm a patent here, but the 150 correspond to 222, just to give you an idea. And if you do the measurement of the ora serrata, you can actually get from 230 and 340 if you actually look through the corresponding angle. So remember, the numbers are important and you have to know how it was measured. So wide field imaging include color, fluorescent ICG, OCT, and OCTA. In my lecture, I will speak about OCT and OCTA, but I would want to show you also some example of a wide field color with different instrument, with single or montage images, or the fluorescent angiography, as you can see here, or the ICG imaging. What about OCTs? Well, if you take, for example, a 55 lens with the hydrogen spectralis, you get such an image. It's bigger than not what you have with a normal 30 degrees, but it's enough. Well, if we follow the suggestion by our Japanese colleague, if you add any 20 diopter lens, you can get a wider field of view. Of course, the quality of the images can decrease because the resolution is depending on the size of the pixel, and the pixel, since are the same number, are a little bit bigger. And of course, the resolution can decrease. But you can also do a composite of different images, or using a swap source with a single 16 millimeter OCT image, or a 23, like the Canon Xephilio S1 can be able to obtain. And if we do a composite, we can actually even get a wider with a 16 with a 20 diopter lens, or you see here with the Xephilio and the composite, you can get a very, very wide field OCT. The most interesting part when we want to get images of the myopic eyes. Here, the example of Heidelberg using the 55 degrees, and you see always the flipping of external, image. This is due to the fact that the image is obtained using a 1.9 millimeter depth that do not allow to keep all the eye in. If we look at a comparison of the same case taken with 4 different instruments, you see that moving from the Heidelberg to the Plex Elite 100 kilohertz or 200 kilohertz and the Xephilio, you get a wider and wider field of view. The most important thing is that if you look here, it's this number. The Z scan dimension is moving from 1.9 through 3 millimeter to 6 millimeter and 5.3 millimeter. So these two allows, a wider field. But again, look at Xephilio, it's really impressive looking at 23 millimeter comparing with 16 millimeters field of view. And if we compare another case here of myopic patient, you can actually see, the difference between the Heidelberg, the Plex Elite 100, the Plex Elite 200 kilohertz, and the Xephilio. There are a series of publications about the ultra-wide field OCTs. This was from Nitin Chandri, and here is the famous image that you probably saw in published in ophthalmology, where a composite image can give you a very, very wide field of view. Here showing a retinoschisis in the periphery. This is another paper showing all the changes in the periphery. And here it's one of our paper that we publish in patient with that we are treated with the ochriplasmin. And you know that ochriplasmin can detach, the vitreous and the traction, but it's not always clear if you really detach the entire vitreous or just the fovea area. And as Paolo shows in his presentation, it's important to go in the periphery to see how the attachment of the vitreous is released or not. This is another paper that we published last year on the peripheral lesions, and I will go through some example here with a hole with the traction, or a schisis here, and there's a detachment there. Again, another detachment that was not visible, as Paolo underlined with the normal, slit lamp and an indirect lens. Here, a peripheral hemorrhage. You actually can see exactly the location, and there is if there is some connection with the retina, or for example, here a peripheral macroaneurysm that you can actually identify and can be the cause of a hemorrhage. Peripheral choroidal lesion, like a melanoma, or you see sometimes you do a wide field autofluorescence, and you actually see this difference between one area and the other, and you see that part looks a little bit more hyperautofluorescent, what is that? It's quite difficult to see if you look at just at the slit lamp. But if you take the OCT, you can actually see that it's a retinal detachment. It's an old retinal detachment that gives such a appearance and the fundus. Another peripheral hole, and please note the traction here of the vitreous attach, or a break here with the retinal detachment. You can actually look at the periphery and documented the hole. In this case, we perform, a laser treatment, and here the OCTs with the detachment retina and the still traction that can actually create a complete retina detachment. And you see here the hole. Sometimes you are not understanding what is going on, and here clearly a traction with the vitreous attached at the edges of this elevated retina, or these folds that is not actually clear if you look at the fundus, but you can actually see very well if you look at the OCT. What about OCTA? Well, there are a series of nice papers showing the importance of OCTA in comparison with fluorescein angiography to detect the area of non-perfusion, particularly to see if the anti-VEGF treatment can reduce the not perfused area. I would say that most of the time, OCTA shows exactly the same thing that you see with fluorescein. Sometimes, and I'm sorry for that, I think that fluorescein can give a little bit more information because you can actually see if there is some leakage in the vessels or not. But again, there is no difference if you actually do in before and after anti-VEGF treatment, detecting with OCTA, the area of not perfusion are still not perfused, even if you do an anti-VEGF treatment. And here are another examples of their publication that shows fluorescein and OCTA quite clear. You see, for example, the disappearance of the new retinal vessel. So you see before and after, and before and after with OCTA. But right now, the only two instruments that are able to give a wide field images, OCT images, are the two swab source. And here, the Xefidio that can actually show all the details. Please note it's difficult to say foveal avascular zone because it's all avascular, and this, I'm sorry, is my eye. And you see how you can actually see details in the fovea, and then look at the entire retina. It's about 100 degrees. But if we look at some diseases, like for example here, some lesion secondary to some not perfused secondary to a central vein occlusion. You see here the not perfused area, and here with a fluorescein angiography with 1 or 2 degrees. But this is what you get with a montage with the Canon Xefidio S1. It's even larger, the field of view. And remember that until, I would say last year, the big concern for OCTA was actually that you were not able to get a wider field of view, so stuck on 9 millimeter at maximum 12 millimeters, but here you get really a very, very huge area. And another case of fluorescein angiography for a diabetic proliferative retinopathy with new vessels. And here it's again the 1 or 2 degrees, and here is the Xephilia montage, where you get even more of the periphery, where you really see other ischemic area that you were not able to see in the fluorescein angiography. So for sure, this type of images can really help us in real world clinical setup. So in conclusion, wide field images was before just color and fluorescent and ICGA. Now with the new machine, we can actually do OCTA and OCT. Thank you.
So now I think we are going into the questions and answers session. I'm looking at, there have been few questions, and I'll tell you in general exactly what the general topics that I've been alluding to. Quite a few questions for you, Tarek, about artificial intelligence, as we thought that it will stimulate a lot of discussion here. And perhaps let me put it in a way that will make more sense. As we understand it, is artificial intelligence is that you feed it with averaged images, which goes into this deep brain somewhere in a huge computer, and then it comes out with algorithms and cleans the image to what is normal, what is not normal. I can visualize that it's quite possible and easy to do with a normal fundus, because all fungi share the same vascular features like capillary network, foveolar vascular zone, disc, arcades, whatever. So it's quite easy for this deep neural network to wipe out the denoise and come up with really meaningful, clean images.
As you know, shown the AI-driven intelligent denoising improves the perceived or subjective quality of the OCTA images. In your experience, how does this translate into the variability and bias of quantitative features such as vessel density?
Well, we haven't looked at those aspects yet. It's a really interesting question, actually. I think it's something, I suspect it will clean up the image. I suspect by removing some of the noisier elements, it will make our algorithms that look at variations with different pathologies even more accurate. But I'm excited to see how it will change. The beauty of it is we can, with this, we can very simply just, plug it in and see which one is better. If it isn't better, we can always go back to the denoised image. So I hope it will actually improve things. The other thing that I hope will improve the quality is by having a broader area to look at, because our initial study was just a 3x3 scan. And then finally, what I would really like to do is look at lots of layers as well. Those three things combined together, I think, I want to try and use to push our sensitivity and specificity so that the area of the curve goes from 0.8 to 0.95 or something like that, when we could really start thinking about it potentially being a non-invasive measure to detect things like diabetes. I'm excited for the COVID stuff as well, because there's been a paper looking at OCTA vasculature that didn't really show any differences with COVID. And what I'm thinking is that although you might not see any to the expert eye, if you start applying the algorithms, then something might come out. If we can get that work going, then that'd be really interesting to see as well.
Can I say just remember one thing? OCTA is showing the lumen of the vessels, not the anatomy of the vessels. So it's quite tricky, but we have to keep in mind, the size of the vessel cannot exactly the same of the, and you can actually have a pathology where you have increase of the size of the vessel if you look in color, but in reality the lumen can be reduced. So could be not a correlation between what you see in the fundus and what you get with OCTA.
That's a very good point. Tarek, beautiful presentation, really, really good. Flow blood flow, speed of flow is also important to take into account, as it can certainly affect findings.
Yeah, it's interesting with all the different imaging now. I think you guys probably agree. It's not really looking at single modality, but using multimodal. And I know both of you, I think, agree with that as well. You get different bits of information from different sources of imaging, but it's one of the things that makes medical retina so exciting at the moment is that we have so many of these different technologies. When I saw your scans, I was like, wow, that's just incredible still. But I still remember, when Paolo, you said in your slides, when you first said OCT is going to be useful, I remember somebody saying, there's a consultant who's got this machine and it gives you this cross-section of the back of the eye. And as some of the trainees, getting the lock to the machine and looking at it was some sort of initial Stratus type machine. And even then, it was just incredible. And just in a short period of time to get to the stage of the imaging that you guys have presented is, we're very lucky to have these sorts of technologies to play with.
I think we're very fortunate to have people like the two of you that keep looking into improving the technology.
One of the things I was going to say is that sometimes I think amongst my colleagues, there's a slight fear of using the different things. And sometimes you only really get used to, OCTA is a lot harder to read than just standard OCT. But I would urge people to start using it because otherwise there'll always be this big chasm and you'll never start learning about how to look at it and look at the images and analyze the images and the utility of it. Just as you showed, Paolo, until you start doing it and you see the advantages of the practical applications, you might just miss that whole thing.
I agree with you. I fully agree, Tariq. I think it's essential that we have a hands-on experience in using the different devices. It makes a very big difference. I do a lot of the scans myself. We've got a dedicated team of technicians at the London Vision Clinic, but even so, I sit with the technicians because there are sometimes, there are specific lesions that what you want to achieve, what you want to see. And I sit in front of the machine and I handle it. And there's some of the images that I've shown, I've taken myself, because you have to process the image, exactly where you want to be. That said, technology has changed significantly, so much more user-friendly than before. I remember when I introduced OCT into the UK clinical setting in 1998, and I was a fellow with Alan Bird at the time. You had to, it was like piloting a helicopter. You needed a trackball and you had two monitors, one so that you would see where you were, the area that you were scanning, another monitor to process the image. And it's all changed. And I remember from my years at Cornell and then spending time with Larry Iannuzzi in his practice in New York, that, there's only one secret, which is spending time. You need to sit in front of the images, you need to stare at them, and you need to, there's nothing replaces that, and which is what the two of you do as well.
Indeed, I mean, in my clinical practice as well, I often take over and do the images because we're still learning really from these images and what we're able to see and how to use it. Certainly, I've managed to get access to the settings of the OCTA, and I've changed a lot of the settings from the standard Canon that give you, just so that it'll allow me to see features more closely or look at the posterior, the back of the outer retinal layers more than the inner retinal layers and so on. So we're all learning, and it is an evolving, amazing technology. I have a question for you, Paolo. You mentioned about flashes and floaters, and for that matter, I extend the question to Giovanni as well. You're able to see retinal tears in the periphery, particularly in cases of flashes and floaters. How practical is that going to be in your VR clinic, or even doing a flashes and floaters clinic?
Well, every single we know we see a lot of myopes because of Dan Reinstein's practice, placing ICLs, apart from having developed a lot of technologies and techniques that are used in refractive surgery. So I have access to a wide range of myopes, and they commonly suffer from myopic vitreopathy, and floaters are very common, and PVD is very common, and PVD taking place at an earlier age, of course. So we have a lot of patients that call us with symptoms of acute flashes of light and floaters, and every single patient that comes to see me undergoes ultra-wide field multi-wavelength imaging before seeing me, and every single of those patients undergoes indirect ophthalmoscopy 360 degrees, and now every single patient undergoes S1 Canon wide field OCT. I cannot imagine myself, to be honest, examining these patients without wide field OCT. And the reason for this, as I'm sure Giovanni and Tariq will agree, it can be very difficult to establish or differentiate PVD from vitreous schisis in a young myope. When the vitreous is syneretic, when the vitreous is liquefied, unless you see a vice ring, it can be very difficult. Of course, you see a vice ring, you know there's a PVD, but the challenge is it just a posterior pole PVD? How much of the vitreous has detached? And 23 millimeter long scans are a game changer. Opposite to what others have done when imaging the peripheral OCT, what I have shown today is not just 3D rendering, which makes it easier to understand, but also 23 millimeter long scans. You are scanning a much larger area, and this is essential. It is essential when you are assessing vitreoretinal attachments, vitreoretinal traction, which are different things. When you are assessing the extent of peripheral retinal pathology. I think, there was a question, I think a lot of patients are underdiagnosed. Perhaps I'm convinced we could be reducing the number of patients showing up with retinal detachments through education. Most patients are now becoming aware of age-related macular degeneration, but they still don't know. Most patients don't know that if you have sudden onset of flashes of light and floaters, you need to be seen. Most of the patients with retinal detachment that we see, when you ask them, they would have had floaters and flashes of light at least 2 to 3 days before. And by the time they show up at accidents and emergency, they have a retinal detachment. If we catch those patients early, most of those patients would be sorted out with indirect laser retinopexy. The difficulty is, in my opinion, that the younger generations are no longer using the indirect ophthalmoscope. It is a big problem because you go to accidents and emergency and you're examined with a slit lamp. And the only place where I know that you can reach the aura with a slit lamp is at the booth in a convention center in those dummy eyes. Otherwise, you cannot see the aura. So it is essential to go back to basics and teach the younger doctors to use the indirect ophthalmoscope and use indirect ophthalmoscopy with scleral indentation. I was a fellow of Harvey Linkoff in New York, and you would get fired. You could fire fellows at that time in the early 90s. Now you cannot. It's a different world. But in the 90s, if you didn't use the indirect ophthalmoscope and you couldn't do indentation, you would have been fired. And that was it. It was a bit like Donald Trump. You're fired. But that's the way it was. And I think we need to encourage the younger doctors to go back to basics and examine the retina aura to aura. It's the only way to diagnose all possible retinal lesions.
Paolo, nowadays, I think the fellows can fire us if they're not happy.
I think you're right.
Yeah, that is true. But the other thing is that we have a huge clinic of we have a huge clinic of oncology, and we actually realized in the last 2-3 years that we have to do so many enucleation because the patient comes with a huge lesion And I'm afraid that this is related to the fact that everybody using OCTs look only at the posterior pole and not anymore at the periphery. So I'm afraid that, OCT is fine, but probably if everybody, since it's much easier to use, instead of an indirect ophthalmoscope or putting a lens, contact lens and see the periphery, if you use regularly a wide field OCTs, probably you get, better visualization of the periphery, and you catch lesion that you cannot see just looking at the posterior pole much more in advance. Because again, last year we moved from, in the last 2 years, we have an increasing of enucleation that was amazing. Really, never done so many.
You're right.
And I'm afraid.
You're right. I personally have no doubts. The same as ultra-wide field multi-wavelength imaging has replaced 35 and 40 degree fundus photography. I think this technology will end up replacing posterior pole OCT. I think this is a real game changer.
Yeah, of course, if you want to see details, okay, you can go and have a smaller scan. But as a first step, you should have a wide field image and then moving to a smaller field, but if you want to see details.
Can I ask you two a question? Just with COVID, you Paolo talked about it, and Gianni, you talked about it. Have you experienced even fewer people coming in and seeing perhaps people ignoring their symptoms more since COVID? Because it's definitely happened in Manchester, I think, where for some reason the number of detachments has gone down, and we're just presuming they're out there in the community, not coming in. Perhaps this sort of technology in an optometric setting might help in years to come.
It's a very valid point, Tariq. This technology being out there in the community would significantly help, especially to confirm the presence or absence of a posterior vitreous detachment. And it is essential for patients to get prognosis. It is essential for patients to know what's happening in the other eye. Sometimes that gets forgotten. The patient comes with two eyes, and people tend to concentrate on the symptomatic eye, but you also want to assess the other eye, because if they do not yet have a vitreous detachment, it is essential to tell them, look, these are the symptoms you need to pay attention to. Any change in existing or new floaters, flashes of light, loss of peripheral vision, loss of central vision, distortion of central vision needs to be reported as an emergency, and you've got my contact details. I tell this to every single patient, and I make a record in the nose, but I always assess the other eye, because if they've got a PVD in one eye, most likely they're going to get a PVD in the other eye. So they need to be prepared to access help to be examined as soon as they become symptomatic in the other eye. And the fact that they didn't have a tear in one eye doesn't mean they will not have a tear in the other. We need to embark in an education campaign. This could save millions of pounds and reduce reduce operations that could have been avoided if we did proper retinal examination.
And I think go ahead, sorry.
I was just going to say, maybe it's like you showed patients the images that might help convince them to come back, because with COVID, they're all frightened. And if you actually...
I'm fortunate that I'm, fortunate in a private clinic, in a private sector. So I work at the London Clinic on Harley Street. We have not seen a drop in patients. I'm busy as before. I guess NHS is different because the same hospitals handle COVID patients. Yeah. We do not see COVID patients.
And probably just to say that probably everybody have the same experience, that a patient comes for flashes in one eye and you find the hole in the other eye. And it's something that you have always to keep in mind, because not always is symptomatic, and you have to always concentrate to both eyes.
But I have a little question for all the panel, really, for that matter. Now we're able to see all the different lacunae in the vitreous, and if there is where the existing PVD is occurring. Will that alter our way of doing perhaps vitreous taps or intravitreal injections, for that matter? Certainly, food for thought.
Well, I believe that assessing the status of the vitreous, the degree of syneresis is going to be essential and may have an impact on half-life of drugs. For example, we have moved into a world of intravitreal injections. Everything is intravitreal now. We're going to be doing intravitreal gene therapy soon. So half-life may be different, whether the vitreous is syneretic or not. Of course, a vitreous tap should be different whether there's a formed vitreous or not. It's very difficult to do a needle biopsy, as we know. If we could assess those patients with wide field Schweppes OCT before, perhaps that could give us an idea of whether the vitreous is syneretic enough to obtain a sample with a needle without taking the patient into theater. But this is work for the future.
Excellent. I don't see any more questions coming through, so I think we'll have to end this webinar. So I would like to start by thanking all the speakers for their excellent and stimulating talks. Absolutely most magnificent and amazing display of images and presentation. So thank you all. I have been privileged working with Canon for quite a few number of years, and I've seen their technology evolving. And I have to say that Canon always pushes the boundaries of possibilities. So I'm sure they have a lot up their sleeve we're waiting to see. So thank you very much, Canon, for organizing this excellent webinar. And apart from my internet connection, I believe it went flawlessly. I hope AI has got a lot to do with this, I'm sure. And thank the audience for joining us and for making this a very stimulating and sociable event, particularly during our lockdown. So remember, everybody, that knowledge is power, and no doubt every one of us have taken a little note today to empower us in the future. So wish you all a very pleasant weekend, and please remember to keep safe. Best to you all.
Thank you again.